All right, welcome back. This will be part 2 of valvular and inflammatory heart disease. This is obviously the valvular portion. So we remember from cardiac assessment, when we were talking about our valves, we kind of talked about all physicians take money, and those are the landmark locations that we are going to auscultate when we suspect we have any kind of valvular heart disease. So it kind of shapes up to be like this, where we have the semilunar valves up top. So the aortic is on the right sternal border, the pulmonic is on the left sternal border. Both of those are usually the second intercostal space. The tricuspid and the mitral valve, again, these are going to be, tricuspid valve is going to be left sternal border, and that's usually fourth or fifth intercostal space. And then the mitral valve is going to be the fifth intercostal space, mid-clavicular line. So we know that we can have changes in the structure of those hearts, especially if we do have or have had one of those other inflammatory disease processes. But multiple things can cause valvular heart disease. We'll look at that slide next. So risk factors, usually we talk about age, history of infections or history of malformations of the valves. Specifically what we're kind of looking for, I'm going to skip over management and clinical signs for now, and we're going to go down to the stenosis or the regurgitation. So we've talked about a stenosis as a narrowing or an increasing. If we're talking about an aortic stenosis, what we're saying is the valve that helps regulate cardiac output has become non-compliant, and you're going to have issues pumping out enough blood to maintain cardiac output. Whereas a regurgitation is more of a backflow, and it's usually because you have some sort of incompetent closure of the valve. And that could be because of structural changes, the inflammatory processes, whatever it may be. Generally speaking, when we're talking about management and clinical signs, it's straightforward for cardiac. There's nothing really different that we would expect. Again, we talked about that is kind of the problem with cardiovascular, is that there are so many it depends. But medical management, at least early on. Surgery, probably save that for much later unless it's an absolute acute situation. And then we'll talk about lifestyle modifications, which we all know what to do for that. So we know that valvular heart disease occurs when one or more heart valves are damaged or malfunctioning. This can lead to any kind of stenosis or regurgitation, so a narrowing or a leaking. We walked through stenosis and regurgitation. The other one that you will hear them talk about, and it's usually mitral valve, is this thing called a mitral valve prolapse. So the valve leaflets actually bulge back into the chamber. So it's still a blood flow issue. Remember early on in cardiac assessment, I said we need to understand where blood backs up to. So here we've kind of reinforcing what we see as far as the all physicians take money. We're seeing our local landmarks and where we should be placing our stethoscope. Notice here we're talking about a leaning forward position for the client or a left lateral recumbent, and in which case, generally speaking, you see that in the first image where the leaning forward, she is using the diaphragm versus the left lateral recumbent, she is using the bell side of that. You guys don't need to know that. You need to know that you're going to listen to heart sounds to assess for information such as a new murmur or an extra heart sound. So valvular heart disease overall, it affects the efficiency of the heart as a pump and can reduce stroke volume. Over time, there are going to be signs and symptoms related to heart failure or hypertrophy or any of those other bad cardiovascular consequences that come with inadequate cardiac output. We've said, and I've got my big arrows over here on the right, that the majority of these issues that I see are going to involve the left side of the heart, so the aortic and the mitral valve. If I had to choose to have one or the other, I would take the mitral valve every day, because we do see lots of complications if you have an aortic stenosis. So in this image, again, what we see kind of is the normal open, close. So this is the actual sound of that we S1, S2, the closing of the valve. And then here we see that I have some vegetation. If you notice all the little crinklies, it just kind of looks like it has an overgrowth. It's probably an overgrowth of calcification that's causing that stenosis. So instead of being nice and open, it's decreasing the lumen of the aortic valve, or affecting its ability to close altogether. So here you can see, let me erase this real quick. On the left side, we see that there is less room on the open aortic valve stenosis, and an incompetent or incomplete closure on the closed side of aortic stenosis. Definite structural changes. We know that some of these changes can be congenital or acquired in nature. So congenital is what we talked about when we're talking about, stenosis of coarctation. You have a stenosis with tetralogy of Fallot. You have an opening with PDA. You have an opening with PFO. So knowing that client's history is going to help us determine if they are at risk for congenital heart disease and valvular heart disease. So what I want to do is kind of look at and investigate the left side of valvular heart disease. You're going to see that a lot of these are going to be the same. So what we're going to do is we're going to focus on what is different. So here we see it's dyspnea, but it's dyspnea on exertion. And they tell you that is related to pulmonary congestion. So you remember we talked about the mitral valve and where does blood back up to. Here, it's still exertional dyspnea, but now we're throwing in angina, syncope. So this classic, or what they're referring to as the classic triad of aortic stenosis. And again, we remember that chest pain is chest pain is chest pain. Until I know that it's not MI, I need to treat it as such. For our dyspnea, on the mitral valve heart disease, they throw in orthopnea, paroxysmal nocturnal, normal respiratory or normal perfusion words, fatigue, palpitations, arrhythmias, AFib, pink frothy sputum, which is going to relate to that fluid accumulation. Whereas with the aortic valve, now we're talking about a widened pulse pressure, bounding pulses, new heart sounds, new extra heart sounds related to the stenosis. Complications are fairly straightforward. You can have dysrhythmias, you can have embolism, you can end up with pulmonary hypertension, which is going to be or manifest as right-sided heart failure or just heart failure in general, versus you can see it's much more severe with an aortic stenosis. I could move all of these complications of mitral valve disease over into our aortic valve complications, and it would still fit that criteria. So again, that just means to us that we already know how to treat heart failure. We know how to treat a bad pump. We're going to do things to change preload, change afterload, decrease SVR, improve cardiac output. So we're going to do that with diuretics, beta blockers, anticoagulation, and ACE inhibitors. The only thing that really changes over here for aortic valve disease, we see beta blockers, which is the same. We say nitrates. Nitrates are only used in aortic valve regurgitation. Okay? If I have a stenosis because of the problems with preload and afterload and how nitrates affect both, it's going to be contraindicated for aortic stenosis. This is where it gets people, because the client came in complaining of chest pain. All right, so it's, again, we're going to do the things that we need to do, but you can see why it's so important to get that 12-lead ECG to tell us whether or not we think that the chest pain is related to demand ischemia or if it's actually true myocardial ischemia. Otherwise, for the most part, your pharmacological management is pretty much the same. Surgical or procedural interventions, it's repair, replacement. It's a PCI, it's send you to the cath lab, it's valvuloplasty, it's commissurotomies, it's whatever we need to do to change that valve to become competent. With aortic valve replacement, AVR, or we see it as TAVR sometimes, you can still see bovine porcine. We used to say, and this was again years ago, that if you had a true aortic stenosis, that really the only outcome once you became symptomatic and we felt that it was no longer going to be competent would be a mechanical valve because of the high pressure that the aortic valve is under. But we now know, or kind of understand better, that these clients are probably towards the end, and the bovine porcine valves are probably going to be able to last at least 7 to 10 years, generally speaking. So it's kind of one of those risk versus reward situations. The risk factors are exactly the same as everything else that we've talked about. Again, if you've had a previous instance of rheumatic fever, if you've had issues with degenerative changes, maybe you have an inflammatory disease process, maybe you have lupus, you have some sort of underlying condition that's going to affect those valves. Congenital heart disease, previous histories of infective endocarditis, long-standing hypertension, Marfan syndrome, basically a connective tissue disorder. Usually it's going to be in our younger clients starting out, and that's how they'll get diagnosed. And then obviously if you've had a history of an MI or heart failure. And all those risk factors are also going to be complications. So we see complications of heart failure, we see arrhythmias, we see embolus, we see endocarditis, we see pulmonary hypertension, and worst case, sudden cardiac death, usually in severe cases. Expected findings can include murmurs, dyspnea, fatigue, dizziness, syncope, chest pain, edema, palpitations, pulmonary congestion. It's simply left-sided, right-sided. And you can kind of figure out from the presentation whether we're talking about the left side or the right side. Generally speaking, in my test questions, I'm not trying to have you guys differentiate, because that's a diagnosis between a, say, mitral valve disorder and an aortic disorder, because that's what the diagnostic testing's for. That's what the doctor is going to tell us, and then we're going to come up with things to do to improve the treatment plan. So to get that information, we kind of expect them to have an echo, which we would consider the gold standard because it allows us to visualize the chambers, the valves, blood flow. A 12 lead, they're going to probably be on continuous telemetry, chest x-rays. We talked about MRIs and CTs. Cardiac catheterization, right? We want to go down and we're going to visualize the effect or the severity of those changes to the valves. So you see here they talk about pressure gradients. And then obviously because it will mimic signs and symptoms of heart failure, you can get a BNP. I would probably throw a troponin in there if they came in complaining of chest pain with aortic stenosis. Your goals have not changed. We want to ensure that they maintain adequate cardiac output. We want to prevent heart failure progression. We want to reduce thromboembolic risks. We want to control their signs and symptoms. All that sounds like a great way of saying treat the underlying cause. Plan of care, frequent vital signs, listen to heart sounds, promote rest. Because again, we're thinking heart failure, it's a sodium and a fluid restriction. And of course, keep them on continuous telemetry to monitor for arrhythmias. Health promotion and disease prevention, kind of different here, right? So we want to prevent and treat bacterial infections. And by different, what I mean is that we know, again, that this is one of those things, when you've had it once, you're more than likely to get it again, these recurrent admissions. So we're going to do lots of patient teaching for health promotion and disease prevention. We're going to talk about the diet, especially if they have signs and symptoms of heart failure, if they had a bad EF, whatever it may be. We want to talk to them about controlling any underlying chronic kind of illnesses. And you guys know it's usually diabetes, hypertension, hypercholesterolemia for plaque, and LDL and HDL and your triglycerides, and just so many things that can feed into valvular heart disease. And of course, we're always going to encourage increasing levels of activity. Just make sure that they understand that it's a comfort thing, really. I want you to be exercising, but I also want you, if you start to experience any signs and symptoms, know enough to say that you don't have to push yourself through those things. We just want you to start that cardiac rehabilitation. The problem with valvular heart disease is the same problem that we have with every other cardiac disease process, is that it's asymptomatic for years until it's not. So again, they may have just generalized weakness, fatigue, palpitations, changes in their respiratory pattern or effort. With the acute situations, we're talking about thready peripheral pulses. How many times have we said that weak and thready pulses are deadly? Cool, clammy skin in the extremities. Obviously, we are thinking shock. We've talked about the signs and symptoms and where blood flows to and where blood should be going. So right-sided, it's the same as signs and symptoms of right-sided heart failure, and that's your tricuspid and pulmonic valve. Left-sided, which is the most common, result in dyspnea, fatigue, decreased cardiac output, and again, that's your aortic and mitral valve. So we're going to talk about those more than we would talk about our issues with the right side of the heart. So with mitral and aortic valve stenosis, we know that this is going to lead to a decrease in cardiac output. So you're going to, again, have that issue with hypotension, tachycardia, weak pulses, and potentially pulmonary hypertension. You do have a poor prognosis when experiencing acute symptoms if we don't do things emergently. Remember, we said with our aortic valve stenosis that nitroglycerin is going to be contraindicated because of its effect on preload and afterload. So, with aortic stenosis, I want you to be most sad, right? Syncope, angina, and dyspnea. It's the most because it is going to have a bigger effect on your ability to maintain cardiac output. Mitral valve stenosis, we throw in a little more arrhythmias, aneurysms, bradycardia, low blood pressure, heart failure, cardiac tamponade, death, embolization. It's just walking you through the ABCs, and all of those are what we would say for any other cardiovascular disease process. So now we're going to look at aortic valve regurgitation. So remember we said regurgitation is just a backflow of blood. Because it involves the aortic valve, what we're going to end up with is this triad of severe dyspnea, chest pain, hypotension. Sounds a lot like shock to me. It's a medical emergency. In severe aortic regurgitation, the buzzword, the key word that I always see in those practice questions are pulses of a water hammer. Again, that's just not something that I have ever felt. Maybe my folks that work in an ED, because they're going to get them in initially and they're going to treat the underlying cause. So again, you guys know I'm a huge fan of repetition. Repetition makes the dreams come true. We talked about mitral valve stenosis or mitral valve insufficiencies. Semantics here. Most of your signs and symptoms are pretty common. What I did is I went through and I highlighted what we would want to know that's kind of different. So if I look at a mitral valve stenosis, we know we've talked about a murmur, and if you look straight across, a murmur is all of that. You saw changes in respiratory rate and effort, you saw changes in heart rate, changes in rhythm, complaints of fatigue. So there's nothing really different for mitral valve stenosis as long as you know that it is going to have an effect on cardiac output. When you go with insufficiency, the only thing that they kind of add in here now is this crackle in the lungs and this atypical chest pain. I don't know how to ask a nurse to differentiate atypical chest pain. So I would never ask you, oh, is it mitral valve stenosis or is it mitral valve insufficiencies? What I would say is a nurse is complaining or caring for a client, probably complaining about the client too. So a nurse is caring for a client with mitral valve stenosis and auscultates a murmur. What action should the nurse take? The nurse is caring for a client with aortic stenosis that is complaining of chest pain. What does the nurse know? What should the nurse do? So mitral valve is pretty straightforward, right? We can expect atypical chest pain and crackles because of fluid accumulation. The same as we would here, right? You got to have some sort of issue with the right side of your heart or where blood is backing up to have JVD and pitting edema. With aortic stenosis or an aortic insufficiency, we see a lot of the same information. The only thing that we throw in here is chest pain, and now we see narrowed pulse pressures. So again, narrowed or widened pulse pressures. This is why from day one we have been talking about narrowed or widened pulse pressures, because they are indicative of a change in cardiac output. With aortic insufficiency, it says nocturnal angina, so it's still chest pain. But now we see a widened pulse pressure. What are those two things going to look like for you? So if we're talking about changes in a client's vital sign with narrowed pulse pressures, and we're saying 120 over 80 is normal, and the fact that that pulse pressure is 40. If I go to 100 over 90, you can see how you're going to lose a lot of cardiac output. So that is a narrowed pulse pressure versus a widening pulse pressure where, there's no set rules for a widened pulse pressure other than are you symptomatic. So what we're looking for, hey, now your systolic is 140, and I'm just going to use a silly number here, but your diastolic is 30. Do you think that we should do something for that? Of course we should, because the issue we know is here. Our pharmacological management is going to be exactly the same. It's diuretics, it's beta blockers, ACE inhibitors, anticoagulants, antiarrhythmics, vasodilators. We're going to treat the underlying cause. We're going to treat their signs and symptoms. And hopefully, since they were admitted, we're going to probably get them sent out for some sort of surgery to help repair or fix whatever the underlying problem for those valves is going to be. We talked about a balloon valvuloplasty. Over here we can see that we're basically going in and pushing open that area of stenosis. So a balloon catheter is passed through the femoral vein, through the atrial septum to the mitral valve, or through the femoral artery to the aortic valve. We're going to inflate that balloon, make sure that you're instituting your precautions, monitoring for bleeding, monitor for signs of embolization, and then frequent vital signs, continuous telemetry monitoring. Valve repair and replacement for that would include that transaortic valve replacement, surgical valve replacement. You can consider a mechanical valve. The issue with a mechanical valve and why we kind of went away from it is that it does require lifelong anticoagulation therapy. We've talked about the fact that we can use bovine porcine, but again, that needs to be replaced kind of every 7 to 10 years. And we're going to do lots of patient teaching for our prophylactic antibiotics, just like we did for inflammatory. The evaluation is I should have improved exercise tolerance. I should have stable vital signs. I should have the absence of pulmonary congestion or edema. And I should have my BNP return to baseline. Again, most of those things are related to heart failure, which is kind of how those signs and symptoms are going to manifest. Okay. So we're going to stress the importance of prophylactic antibiotics, especially before any kind of invasive dental procedure or respiratory procedure. We're going to teach them to monitor for weight gains, just like we did for heart failure. Still want to coordinate their activities with planned periods of rest, with energy conservation, do just enough activity until you can no longer tolerate it. Make sure that they are participating in their cardiac rehab. They're compliant with their dietary restrictions. We're going to include things like, don't use a lot of caffeine. I'm not going to tell somebody not to drink coffee, but, it's moderate. Same thing we would say with the alcohol. And same thing we would say with the stop smoking, right? Fever should be reported immediately. Again, these clients have had this issue once. They're more than likely to have it again. They may have a petechial rash. They may have shortness of breath. Well, again, we're going to want to teach them to report all of those signs and symptoms of heart failure to their healthcare provider. That is the end. So again, I try to keep this information as simple and straightforward as possible, and I just really think about the big pieces that we're talking about our valvular heart disease.